Este simposio es auspiciado por Astrazeneca y tengo el honor de compartir esta mesa con tres grandes investigadores para discutir con ustedes un tema realmente relevante. Hoy tuvimos una sesión en la que hablamos de Dapagliflozina y diabetes y el tema hoy es, para este simposio, hablar de Dapagliflozina en enfermedad renal crónica no secundaria diabetes, un nuevo horizonte para el paciente renal. Este es el temario que vamos a seguir en aproximadamente 1 hora y 20. Yo presentaré una introducción sobre el estudio Dapa-CKD y el por qué usar inhibidores SGLT2 en nefropatías no asociadas a diabetes. Después tendremos al doctor David Wheeler, que nos hablará de nefropatía por IgA, el doctor Glenn Chertow, que nos hablará de glomerulosclerosis focal y segmentaria, y finalmente el doctor John McMurray, que hablará de corazón y riesgo vascular, para terminar con discusión, preguntas y algunas cuestiones. Solo quiero brevemente presentarles a los ponentes del día de hoy, que son verdaderamente notables. El doctor Wheeler, que vive en Londres, es profesor de nefrología y consultante honorario de nefrología, primero de la Universidad de Londres y del Royal Free NHS Foundation. Ha estado en muchos steering committees, como pueden ver, fue coordinador de CADIGO, ya fue presidente de la Asociación Renal del Reino Unido y tiene más de 350 publicaciones. Boy, that's not Glenn Chertow. Esa foto es John McMurray, I'm sorry.
And a very old photograph.
Yeah, and that's an old photograph. I'm sorry. Anyway. Nuestro segundo ponente es el doctor Chertow. No es su foto, esta es la foto del doctor John McMurray, pero el doctor Chertow es profesor de la Escuela de Medicina de Stanford, miembro indiscutible de un número muy grande de estudios, coeditor del Brenner y tiene más de 500 artículos. Y John McMurray, profesor de cardiología y director del Instituto Cardiovascular de Glasgow, consultante honorario y visitante de Harvard y expresidente de la ESC, la Asociación Europea de Cardiología. Todos ellos miembros del comité ejecutivo. Yo les muestro mis datos de declaraciones de interés para la presentación. Trabajo para el Instituto Nacional de la Nutrición, para la UNAM, y trabajo en consultoría de proyectos científicos diversos ahí anotados. Quiero pues nada más sentar el antecedente. Lo primero, los inhibidores SGLT2 demostraron un efecto de clase al disminuir los eventos renales compuestos, pero esto era en estudios con desenlaces cardiovasculares primarios. Ya Empareg con empagliflozina, Canvas con Cana, Declare con Dapagliflozina mostraban que había una franca mejoría en los desenlaces renales, aun cuando estos eran desenlaces cardiovasculares. El primer estudio relevante en el área renal con desenlaces primarios fue el estudio Credence, un estudio importante que se publicó en el 2019 y que demostró lo que se había sospechado en los estudios anteriores, lo que se había encontrado, pero no era un desenlace primario. Para ponerlo en términos correctos, no era una sospecha, era un resultado de un objetivo secundario. Aquí, como objetivo primario, canagliflozina mejoró notablemente el desenlace renal compuesto, así como sus componentes, como puede verse aquí a la izquierda. Ahora, esta diapositiva seguramente la han visto todos. Lo que quiero yo resaltar en la misma es que recordemos los nefrólogos que aun cuando estos fármacos nacen como hipoglucemiantes orales, hoy sabemos que su efecto hipoglucemiante es leve, es discreto y las formas en las que pueden influir protegiendo al riñón son múltiples, desde hemodinámicas, mejoría neurohumoral, inflamación y fibrosis, oxigenación tisular, todas ellas no son exclusivas de la nefropatía diabética y por lo tanto surge la inquietud y empieza la investigación en el área de la nefrología no relacionada con diabetes. Dapa-CKD es el primer gran estudio que que evalúa esto en pacientes diabéticos y no diabéticos. Este es el diseño de Dapa CKD. Recordar, y aquí lo pongo en rojo, que fueron casi 4.300 pacientes, podían ser diabéticos o no diabéticos, con más de 18 años, con esta filtración de 25 a 75 y con proteinuria. Sí se excluyeron algunas enfermedades renales como la poliquística, la lúpica, las vasculitis, la diabetes tipo 1 y todas las glomerulopatías que estuvieran o hubieran recibido recientemente inmunosupresión o esteroides. Dapa contra placebo, seguidos supuestamente en promedio por 2.4 años, alcanzar 681 eventos con este objetivo primario que todos conocen y hemos discutido, pero que se suspendió antes porque el grupo de Dapa mostró beneficios antes de juntar estos 681 eventos. Este es el diseño, Dapa contra placebo. Nuevamente, aquí están los criterios de inclusión y de exclusión, y el primario es el compuesto de deterioro de más de 50% en la tasa de filtración, enfermedad terminal, requerir diálisis o trasplante, muerte renal o cardiovascular, con estos secundarios que se anotan aquí y que hemos discutido reiteradamente. Esta diapositiva es particularmente importante. Si vemos aquí, y lo más importante es que se fijen en esta barra, pues alrededor del 60% de los pacientes tenían nefropatía diabética. Eso quiere decir que hay un 40% con otras etiologías. Nefropatía hipertensiva y isquémica, glomerulonefritis crónicas, causas desconocidas, otras. Les muestro solo muy brevemente algunas características basales. Diabéticos fueron 2.900 y no diabéticos 1.398, casi 1.400. Y como es esperado, hay diferencias. Los diabéticos son más añosos, tienen presiones sistólicas un poco más altas, tienen un índice de masa corporal de 30 contra 27, obviamente la hemoglobina glucosilada es lo que los diferencia. Aquí obesidad, dense cuenta qué porcentaje tan alto, de casi el 50%, más hipertensos, aunque no es tan diferente ya, y muy importante, y en relación a lo que John nos va a platicar también, pero mucha mayor enfermedad cardiovascular en los pacientes diabéticos que en los no diabéticos. En los fármacos que recibía hay algunas diferencias, pero no muy significativas. Pero cuando vemos las características renales basales, pues vemos que la filtración no es muy diferente, 1,6 contra 1, la creatinina, la filtración 43 contra 41, y la subdivisión por grupos o por categorías de filtración glomerular o de albuminuria tampoco son demasiado diferentes, solo mostrando que los diabéticos tienen un poco más de albuminuria. Como recordatorio, porque no vamos a ver más de esto, el objetivo primario compuesto fue claramente beneficioso para los pacientes que recibieron Dapagliflozina con este 39% de reducción de riesgo relativo y este valor de P impronunciable, pero aquí hablamos de todos, diabéticos y no diabéticos. Objetivos secundarios, 44% de reducción del renal secundario excluyendo muerte cardiovascular, 34% reducción de diálisis y trasplante, 29 cardiovascular, 31 muerte por cualquier causa. Y quiero que vean esta diapositiva antes de terminar. Aquí tenemos en azul el total del desenlace primario. Aquí tenemos en esta segunda nefropatía diabética y después tenemos nefropatía hipertensiva, glomerulonefritis y otras causas. Todas a la izquierda de la unidad, todas claramente hacia la izquierda, algunas tocan la unidad, por supuesto, porque el número de sujetos es realmente no muy grande y es difícil que se alcanzara significancia porque el estudio fue diseñado para la población global. Sin embargo, dense cuenta cómo las glomerulopatías están claramente incluso más a la izquierda que la nefropatía diabética. Con esta termino para recordar que hay tres grandes estudios en la población en la población diabética y no diabética. Credence, solo diabéticos. Dapa acerca de diabéticos y no diabéticos con los resultados que hoy escucharemos de nuestros amigos y colegas. Y finalmente el estudio EMPA-Kidney, que no ha terminado, que está en curso, que tiene diabéticos, que tiene no diabéticos y que también tendrá diabéticos tipo 1. Y con eso dejo de proyectar para pasar, déjenme dejar de proyectar para pasarle la voz al siguiente de nuestros ponentes. Y por favor, David, thank you very much for being here. It's your time to talk with us about IgA, and thank you indeed very much for your patience and for joining this meeting today with us. Muchas gracias.
Thank you, Ricardo. It's an honor to be with you here today. I'm just going to try and share my screen, if I may. And I'm hoping you can see my screen there. Is it good, Ricardo?
Yes, we can, and we can see and hear you perfectly.
Fantastic. Well, look, as I say, thank you for the invitation to speak. I'm going to talk to you, as you heard, about the subgroup of patients who were recruited into this trial with a diagnosis of IgA nephropathy. So I think we've got a lot of the background already from Ricardo. You all know what IgA nephropathy is. It's one of the commoner types of glomerular disease. It's seen around the world, and we have few treatment options. So for most patients, we offer RAS blockade. We may offer immunosuppressive therapies, but we have not got good trials to demonstrate efficacy of these interventions. Now, we know that SGLT2 inhibitors have demonstrated nephroprotective effects in patients with type 2 diabetes and chronic kidney disease. And as Ricardo has told us, the Dapa CKD study extended these findings to patients who had chronic kidney disease, but didn't necessarily have diabetes as a comorbidity. So a third of the patients going into this trial had chronic kidney disease due to causes other than type 2 diabetes. And you've heard the headlines from the trial. Compared to placebo, dapagliflozin reduced the risk of kidney and cardiovascular events and prolonged survival. Now, in this study population, we had 270 patients who had a diagnosis of IgA nephropathy. And this was a diagnosis as reported by the investigator. And we understand from the investigator's report that the majority of these patients, all but 16 of them, had had a kidney biopsy to prove the underlying diagnosis of IgA nephropathy. So we were interested to see what happened to these individuals during the Dapa CKD study. Ricardo's already been through the outcomes of the trial, so we know about the primary outcome and the various secondary outcomes in this trial. For this analysis of the IgA subpopulation, we did some exploratory outcomes looking at rate of decline in eGFR and reductions in urinary albumin to creatinine ratio. So out of the 270 patients with IgA nephropathy going into this study, 137 were randomized to dapagliflozin and 133 to placebo. And you can see here the baseline characteristics of these patients, which were generally well balanced. The mean eGFR of this subpopulation was 44 mils per minute. The median urinary albumin to creatinine ratio was 900 milligram per gram, close to a gram of albumin per gram of creatinine. The only possible imbalance here is that more of the patients randomized to dapagliflozin had type 2 diabetes as a comorbidity. So of course, some of these IgA nephropathy patients also had diabetes. And as I've said already, the diagnosis was confirmed by biopsy in all but 16 of these patients. So just looking at the total study population on the left, 6% of the participants in the trial had a diagnosis of IgA nephropathy. Looking at those with IgA nephropathy on the right-hand side here, 14% of those with IgA nephropathy had a diagnosis of diabetes. So this is the primary outcome of the study, which you'll remember was the composite of 50% or greater decline in EGFR, reaching end-stage kidney disease or death due to a kidney or cardiovascular cause. And you'll see here a 71% reduction in the risk of this endpoint, favoring dapagliflozin over placebo. This is the first of our secondary endpoints. This is the primary endpoint with cardiovascular death taken out. So this is a kidney-specific outcome. This is progression of kidney disease. Again, a large reduction here in the hazard ratio of the patients randomized to dapagliflozin. Only 3.6% reached this endpoint, compared to 15% of those patients with IgA nephropathy randomized to placebo. So just stepping back and looking at various outcomes in the trial, the primary composite at the top, the kidney specific that I've shown you, the development of end-stage kidney disease, and a composite endpoint at the bottom of chronic dialysis, kidney transplantation, or kidney death. So more of a broader composite kidney endpoint. You'll see that for all of these endpoints, the outcomes were better in those participants randomized to dapagliflozin compared to placebo. And these reductions reach nominal statistical significance, except for the composite at the bottom of dialysis, kidney transplantation, or kidney death. But all aligned in terms of the benefit. So one criticism could be that we didn't have a biopsy diagnosis in all of these patients. And so we did a sensitivity analysis looking at just those patients who'd got biopsy-proven IgA nephropathy. Remember, that was 94% of this subpopulation. And you'll see here results consistent with the results for the IgA group as a whole, primary outcome on the left, kidney-specific outcome on the right. We're still seeing big reductions in these outcomes in those patients who had biopsy-proven disease. So taking out those who had not had a biopsy did not make a big difference to the conclusions of our analysis. Now, we did look at the participants with IgA nephropathy according to their baseline EGFR and according to their baseline level of albuminuria to see whether there are any differences. So in the top of the forest plot here, you'll see participants with IgA nephropathy who went into the trial with an EGFR less than or greater than 45 mils per minute. And at the bottom, you'll see patients divided by level of UACR going into the trial, more than or less than a gram per gram. And you'll see here generally results are consistent. For the EGFR of greater than 45 mil per minute, we actually had no events in the participants randomized to dapagliflozin, so we're not able to complete this forest plot here, but generally consistent results in those patients who went in with EGFRs below and above 45 mils per minute, and those who went in with UACRs below and above 1,000 milligram per gram. So we're now looking here at the EGFR plot during the study. So we took blood samples at regular intervals during the trial, and we were able to plot changes in EGFR over time. And what you see here is at the 2-week time point where we had a blood and urine sample, an acute drop in EGFR in those patients randomized to dapagliflozin, followed by a slowing of the rate of decline of EGFR from that point onwards. So this is consistent with the results overall from the study. We see this acute drop in EGFR in those randomized to dapagliflozin, not seen in the placebo group, and then a slower rate of decline thereafter. And if you look at the chronic slope, that is the slope after this 2-week time point, you'll see that the rate of decline in the dapagliflozin group was minus 2.2 mils per minute per 1.73 meters squared per year, compared to minus 4.6 mils per minute per 1.73 meters squared per year in those randomized to placebo. Now, we also looked at changes in urinary albumin to creatinine ratio. In those randomized to dapagliflozin, we saw a 26.3% reduction in UACR from baseline. The differences are not quite as marked at later time points in the study, but a 26% EGFR, a 26% UACR reduction in the trial. And there were also some reductions in blood pressure. These are clearer in the earlier stages of the trial. But if you look at the mean treatment effects at the bottom here, 3.5 millimeter reduction in systolic pressure on the left-hand side, and 2.2 millimeter reduction in diastolic blood pressure here on the right-hand side. And these are effects that we expect to see with SGLT2 inhibitors particularly in diabetic populations, but also present in this population who have non-diabetic or largely do not have diabetes and certainly have non-diabetic kidney disease. Looking at safety outcomes, there's no real imbalance here in adverse events leading to discontinuation of the drug and in any serious adverse events. In fact, if anything, there were numerically fewer serious adverse events in those participants randomized to dapagliflozin. So to conclude, this was a pre-specified analysis of participants who went into the trial with IgA nephropathy. Those patients randomized to dapagliflozin with IgA showed a reduced reduction in our primary composite outcome, a slowing of the rate of decline in EGFR, reductions in albuminuria, reductions in blood pressure. The drug was safe and well tolerated, and we would argue that this drug offers a novel therapeutic option for patients with IgA nephropathy to slow decline of kidney function. Thank you very much, Ricardo.
Thank you. Thank you very much. Indeed, David, it was a great presentation. And our next speaker, I'm going to share the screen for 1 second because I'm going to try to correct my, I'm going to try to correct what I did. And what I did is that I had the wrong picture of my very good friend, Glenn. Ahora en español. Perdón. Repito mi presentación del doctor Chertow porque tuve un error, estaba la fotografía equivocada. Agradezco al doctor Wheeler su presentación que estuvo realmente muy clara y muy objetiva. Y nuestro siguiente ponente es el doctor Glenn Chertow. Ya mencioné que él es profesor de medicina y jefe de división de la Escuela de Medicina de Stanford y que ha sido miembro y líder de un número muy importante de estudios. Además, él es coeditor del Brenner and Rector, que todos sabemos que es, y tiene más de 500 artículos. Gracias, Glenn, por estar aquí con nosotros. Dejo de presentar para darte la palabra. Por cierto, creo que mi amigo Glenn Chertow va a presentar en español. ¿Es correcto, Glenn?
Sí puedo, gracias.
Excelente. Muchas gracias.
Pues yo quisiera dar las gracias a todos que estaban a cargo de esta conferencia para darme la oportunidad de hablar con ustedes, especialmente en mi español bastante malo. Esta es mi declaración de intereses y he servido como consultor por Astrazeneca, patrocinador de este estudio. Pues la glomerulosclerosis focal y segmentaria, GEFS, es la causa más frecuente de síndrome nefrótico en la población adulta. En el curso de 10 a 20 años, De 40 al 70 de los pacientes con GEFS progresan a ERCT, kidney failure. El bloqueo del sistema renina, angiotensina, aldosterona, así como las terapias inmunosupresivas. Sin embargo, los datos sobre la eficacia de estos tratamientos es limitado. Los SGLT2 inhibidores han demostrado un efecto nefroprotector, como ha visto en las presentaciones de mis amigos en diabéticos tipo 2, independiente de las concentraciones de glucosa, y ahora en otras condiciones como Iga Nephropathy. Y recuerdan ustedes que el estudio Dapa-CKD incluyó individuos con ERC con y sin diabéticos tipo 2. Y comparado con placebo, Dapagliflozina redujo el riesgo de desenlaces renales y cardiovasculares y prolongó la sobrevida muy fuerte. En Dapa-CKD, 2.7% pacientes tenían EFS, lo que permitió investigar los efectos en este grupo, en esta subpoblación. Pues el estudio incluyó pacientes con un TFG entre 25 a 75 y UACR entre 200 y menos que 5,000 miligramos por gramo. Y hay algunas personas con GEFS que tienen más, pero estaban 115 participantes en el estudio con este diagnóstico. Pienso que hay 9 por 10 que tiene biopsia y ha visto las desenlaces. Pues esta información describe las características basales de los pacientes con GEFS. 53 que recibió Dapagliflozina y 62 con placebo. Y puede ver que hay más o menos similares por los dos grupos, entendiendo que el número son bastante pequeños. Y esta es la intención Forest por los dos grupos, el grupo de Dapagliflozina y el grupo de placebo. Y por cada grupo no hay hay un grafía de glomerulonefritis y del grupo de GEFS. Y puede ver que los efectos son similares al grupo de glomerulonefritis y del grupo más grande de personas sin diabéticos tipo 2. Y hay casi mitad de desenlace primero compuesto. Y este es un dibujo de la TEG de los dos grupos, el grupo de Dapagliflozina en azul el grupo de placebo en naranja y puede ver los efectos similares de Iga Nephropathy que ha presentado Dr. Wheeler, que hay menos progresión en las personas que ha recibido la dapagliflozina. Y la diferencia es sobre 1 ml por minuto por año. Y este es un dibujo importante y ha dicho a nosotros que las personas que tienen una experiencia de UACR, de reducción en UACR, hay más reducción en las personas de dapagliflozina. Y en otro trabajo que el grupo con el grupo nosotros están trabajando, las personas que tienen una reducción de UACR tienen más buen efecto en estimated GFR, en TFE. Pues dice que los desenlaces de seguridad ha visto más frecuentemente en el grupo de dapagliflozina. Cualquier evento adverso grave sobre mitad y hay solamente un poco más que eventos a discontinuación de medicamento del estudio, pero menos eventos adverso grave. Pues en pacientes con diagnóstico de GEFS, la dapagliflozina redujo el riesgo de un desenlace compuesto primario 53% en vez de placebo. Los resultados son consistentes con los resultados globales en el estudio Dapa-CKD y con otros tipos de glomerulonefritis. Atenuó la declinación de TFE en vez de placebo y fue bien tolerado sin hallazgos de seguridad inesperados. Pues quisiera dar 3,000 gracias a todos los pacientes que han participado y sus familias y el equipo de investigadores, Dr. Wheeler, Dr. McMurray, Dr. Corre-Rotter, por supuesto, y el equipo de Astrazeneca y los miembros del comité de adjudicación de eventos. Muchas gracias para participar conmigo, especialmente en mi español bastante malo. Gracias, muchas gracias.
Muchísimas gracias, Glenn. Primero debo corregirte. Tu español es cada vez mejor y tu presentación fue muy clara. Así que la agradecemos en verdad y ya habrá tiempo para algunas preguntas o para algunos comentarios. Por el momento, quiero dar paso al doctor John McMurray. El doctor McMurray nos hablará de falla cardíaca en el paciente con enfermedad renal crónica. Y solo antes de darle la palabra, quiero reiterar algo que he venido yo diciendo y que se multiplica en todos los foros. Esta división artificial que hacemos entre corazón, riñón y otras partes del cuerpo ese es nuestro problema. Y ese problema tenemos que resolverlo porque el paciente es solo uno. John, thank you very much. I think your talk's going to be fundamental and of great importance for the nephrology community. Muchas gracias.
No, I'm under too much pressure because not only do I not speak Spanish, I can hardly speak English. And you've got these high expectations. So I'm going to talk about heart failure. These are my disclosures. So let's start by saying, why are we talking about heart failure? And actually Dapa CKD, which you've heard a lot about, shows us very beautifully why heart failure is a very important thing to talk about. Because here you can see the primary outcome and our other major pre-specified outcomes according to history of heart failure at baseline. Patients with a history of heart failure at baseline are shown by the dotted interrupted line. Patients with no history of heart failure at baseline shown by the solid lines. So here's the primary outcome, largely driven, of course, by kidney events. And you can see that this is a bit more frequent in patients with heart failure than in those without. But if you look at our key secondary cardiovascular composite outcome, the composite of cardiovascular death or heart failure hospitalization, clearly there is a much larger difference here where the risk is, as you can see, many times greater in patients with a history of heart failure at baseline. That's obviously true for heart failure hospitalization and true also for all-cause mortality. So very simply, if your patient has heart failure as well as chronic kidney disease, they are at least as high a risk of kidney failure and at a much greater risk of heart failure hospitalization and sadly death as well. So obviously we would like to prevent heart failure if we could in patients with chronic kidney disease. If we can't prevent it, we certainly want to treat it to try and reduce this morbidity and mortality. And of course, I haven't talked about symptoms and quality of life, which are really, truly dreadful in a patient who has both of these problems. So how can we prevent heart failure in patients with chronic kidney disease? So really there are three treatments that we have. One is an older, well-established treatment, and there are two new recent breakthroughs. So let's go through these very quickly. I don't need to tell you about this. These are data that are now just over 20 years old, believe it or not. Two trials with an angiotensin 2 type 1 receptor blocker, an angiotensin receptor blocker, renal with losartan, obviously showing reduced risk of progression to kidney failure, but also showing reduced risk of heart failure, a 32% relative risk reduction in heart failure hospitalization. And of course, this finding was repeated in another trial with a different ARB, this time the IDNT trial with irbesartan. Interestingly, this trial had a third arm in addition to placebo and irbesartan, and that of course was an arm using amlodipine. It's very important to point out here that amlodipine did not reduce the risk of heart failure hospitalization. In fact, if anything, there was a trend to an increased risk of heart failure hospitalization. And what this tells us is that there's something special about angiotensin receptor blockers. This certainly wasn't about blood pressure reduction. There was at least as much blood pressure reduction with amlodipine. This was something special to inhibiting the renin-angiotensin system. And of course, we now have new evidence with a so-called non-steroidal mineralocorticoid receptor antagonist, an MRA that is believed to have different properties that include more effect in the heart and perhaps less effect in the kidney, less risk of hyperkalemia. And this drug, finerenone, has been studied in 2 trials. The first, which is reported and published, the Fidelio DKD trial, as you can see here, was a trial using this novel mineralocorticoid receptor antagonist in patients with chronic kidney disease due to type 2 diabetes. You can see the other relevant inclusion criteria here. And to the right of this slide, you can see the primary endpoint, which was largely about reduction in kidney failure, and the secondary cardiovascular composite endpoint. Both of these endpoints were reduced significantly by finerenone. You can see here there was an 18% relative risk reduction in the renal outcome, and there was a 14% relative risk reduction in the cardiovascular composite outcome. This reduction was largely driven by a decrease in heart failure hospitalization. And you will have heard recently a press release reporting that the second trial with this agent finerenone has now completed, has met its primary endpoint, which in this study was the cardiovascular composite endpoint. So the endpoints were sort of reversed in the Figaro compared to the Fidelio DKD trial. And we will shortly hear the full results of this trial in the next couple of months at the European Society of Cardiology Congress. So evidence that a mineralocorticoid receptor antagonist is also beneficial. But of course, both of these treatments have really only been tested in patients with chronic kidney disease due to type 2 or due to diabetes. Now we have evidence, of course, from the Dapa-CKD trial, along with other trials, that SGLT2 inhibitors are beneficial in patients with CKD, whether it's caused by diabetes, or as you've already heard tonight, whether it's caused by other kidney diseases. So we actually have 4 SGLT2 inhibitor chronic kidney disease trials. 3 of these have completed. 1 is currently ongoing. The first to complete, of course, was the Credence study with canagliflozin. Here is the key cardiovascular composite outcome, cardiovascular death or heart failure hospitalization, reduced by about 30%, highly statistically significant relative risk reduction, driven by a very substantial reduction in heart failure hospitalization. But again, a study exclusively in patients with type 2 diabetes. The second SGLT2 inhibitor study in patients with type 2 diabetes was with sotagliflozin. This is actually an SGLT1/2 inhibitor, although it's about 20 times more potent an inhibitor of SGLT2. Again, only in patients with type 2 diabetes. And as you can see here, again, a very striking benefit on a cardiovascular composite outcome. Of course, this is driven by a reduction in worsening heart failure events. But of course, the key breakthrough, and the one that you've been hearing about already this evening, was the Dapa-CKD trial, where not only patients with type 2 diabetes were included, but also patients with chronic kidney disease who did not have type 2 diabetes. And as you've heard already, in the Dapa-CKD trial, there was a reduction in the primary composite endpoint, driven largely by kidney failure events, but there was also a reduction in our pre-specified secondary cardiovascular composite outcome, again, cardiovascular death or heart failure hospitalization, just as in the Credence study, and again, just as in the Credence study, around a 30% relative risk reduction in this composite outcome, driven by an even larger, almost 50% reduction in heart failure hospitalization. But remember, both in patients with and without type 2 diabetes, and this benefit was similar in patients with and without type 2 diabetes. And here is the breakdown of Dapa-CKD patients according to their history of heart failure at baseline. As you can see here, we had about 470 patients who had a history of heart failure at baseline in Dapa-CKD. As I showed you earlier, they were at much higher risk of cardiovascular events and of all-cause mortality. And here you can see that in these patients, there was a reduction in cardiovascular death or heart failure hospitalization with dapagliflozin compared to placebo. You can see here there was also clearly a reduction in patients without a history of heart failure hospitalization, but this is now taking us into the realms of the use of SGLT2 inhibitors, not only to prevent the development of heart failure, but also to treat heart failure. I just want to spend a few minutes in finishing talking about the treatment of patients with chronic kidney disease who've got concomitant heart failure. Now, we cardiologists, like you nephrologists, divide our patients into different phenotypes or etiologies or whatever you want to call it. And we largely talk about heart failure with reduced ejection fraction, where the problem is with the contraction and emptying of the left ventricle. The left ventricle is dilated and contracts poorly compared to normal. The other principal heart failure phenotype is more about the relaxation and filling of the left ventricle. The left ventricle tends to be hypertrophied, fibrosed and stiff and doesn't relax and fill properly. The patients end up with the same problems: breathlessness, peripheral edema, fatigue. For patients with heart failure and reduced ejection fraction, we are writing our new guidelines this year all around the world, and all of these guidelines say that there are 5 key pharmacological strategies to treat patients with heart failure and reduced ejection fraction. All of these reduce mortality. We believe that they're all mechanistically independent of each other. They act on different pathophysiological pathways. Their benefits are additive. And the most recent of these, of course, is SGLT2 inhibition, because we've also had 3 trials with SGLT2 inhibitors, dedicated trials in patients with heart failure with reduced ejection fraction. And here you can see the benefits of 3 different SGLT2 inhibitors in these trials on our favorite composite endpoint, which is cardiovascular death or heart failure hospitalization, but also cardiovascular death itself, and indeed death from any cause. And what you can see is this remarkably consistent benefit. There is about a 25% relative risk reduction in cardiovascular death or heart failure hospitalization when you add an SGLT2 inhibitor to extremely good background therapy in these patients. So in these trials, patients were very well treated with RAS blockers, with beta blockers, with mineralocorticoid receptor antagonists, and even with sacubitril, valsartan, and angiotensin receptor neprilysin inhibitor. And despite that excellent background treatment, we saw this further large reduction in risk. Now, these 5 treatments can actually be given in 4 pills, because 2 of them, RAS blockade and neprilysin inhibition, are combined in the sacubitril valsartan tablet that's available in almost every country. Sadly, we haven't made as much progress in the other principal heart failure phenotype, heart failure with preserved ejection fraction. And whereas we have a wealth of treatments that are effective in HFrEF, we have really no treatment that is approved globally for patients with heart failure and preserved ejection fraction. Although recently the US Food and Drug Administration did extend the indication for sacubitril valsartan to at least a proportion of these patients, people who have an ejection fraction above 40%, but still below normal. I have to admit, however, that the problem is that for all these treatments I've told you about, with one exception, we really don't have much evidence in people with more advanced chronic kidney disease, because in most of our trials, we excluded patients with an EGFR below 30. So really, patients with stage 5 CKD are a bit of an unknown. In fact, stages 4 and 5 CKD are a bit of an unknown quantity in terms of evidence for efficacy and safety. It's a bit of an evidence-free zone, sadly. Although that's not true, as I showed you a few moments ago, for SGLT2 inhibitors, because as I mentioned in Dapa CKD and indeed also in the Credence study, we do have evidence that in patients who've got CKD and who have heart failure, as you can see here, the benefit of SGLT2 inhibition is really identical to the overall benefit in the trial. So for each of these pre-specified outcomes in Dapa CKD here, you can see the overall treatment effect, which you heard about earlier. You can see the treatment effect in patients with heart failure at baseline and the treatment effect in patients who don't have heart failure at baseline. You can see that for patients with heart failure at baseline, dapagliflozin is effective. And I'm just going to finish with just reinforcing that by looking at all-cause mortality. This is, I think, everybody's hardest endpoint. We would all agree that improving survival is a very important thing to do, but a very difficult thing to demonstrate with any treatment. But here you see the findings in Dapa CKD. Here are the patients with a history of heart failure at baseline. So these are more the patients with heart failure that you as nephrologists see than we as cardiologists see. If you look at the placebo group, they clearly have a very high mortality, more than 20% by about 2.5 to 3 years of follow-up. And you can see that that is clearly reduced by dapagliflozin. The absolute risk reduction here over a relatively short follow-up period is 6.957 events per 7 patients, avoid death per 100 treated. The number needed to treat to prevent 1 patient dying during the median follow-up in Dapa CKD was only 15. There are very few treatments that have such a large effect on all-cause mortality. So it's been very exciting times in both CKD, as you know, and also in heart failure, because we've had several new therapeutic breakthroughs in heart failure in the past 2 years, but by far the biggest is SGLT2 inhibition, which, as I showed you, is now already established as a new standard therapy for patients with heart failure, like it should be a new standard therapy for patients with chronic kidney disease. Fortunately, it treats patients who have both of these problems very effectively, protects their kidneys, protects their hearts, and keeps them alive. Thank you very much.
Thank you, John. Can you hear me?
Yes.
Okay. Very, very nice. This has been a great symposium, and we have plenty of time for a few questions. And I'm trying to see what we have from the audience. Not too many, but there's a few. First one that I will post to David and Glenn both. Carlos Zúñiga. Hello, Carlos. Carlos Zúñiga is asking us, what would you say is the GFR limit for the use of dapagliflozin in patients with CKD? He did not ask about what's the GFR to initiate or to continue. So please abandon the topic. Glenn? Your mic, you have to turn on your mic.
Pues voy a hablar en inglés.
I'm sorry, I was asked to make the questions in English to my friends to make this friendlier and easier. But I still remember my Spanish. Not very well, but I do.
Pues gracias, Ricardo. A very important point to make is that in the Dapa CKD trial, there was no GFR or estimated GFR at which the protocol instructed or demanded us to stop dapagliflozin. And many patients continued to receive dapagliflozin throughout many, many months of having estimated GFRs well below the entry criteria for the trial, which, just to remind the group, was an estimated GFR at screening of 25 ml per minute per 1.73 meters squared. In fact, at randomization, some of those patients who had screening estimated GFRs in the 25 to 30 range had estimated GFRs at randomization that were below 25 ml per minute, and patients continued to receive the drug at initiation and over the course of the trial. We saw no increase in adverse events in the subgroup of patients with stage 4 CKD, nor did we see an increase in the number of adverse events over the course of the trial as the GFR declined in the dapagliflozin treated patients. So it would be difficult to say at what GFR to initiate therapy, but I would say certainly as low as 25 or even slightly below that level, we have evidence of safety and consistent or efficacy that's consistent with patients with higher estimated GFRs. Whether one would initiate dapagliflozin in patients with much lower GFRs remains a question. It certainly does not lower the glucose very well at very, very low GFRs. But on a personal level, I can tell you in my own practice, I am initiating dapagliflozin therapy in patients with estimated GFRs in the range of 20 and above.
Thank you. Can I ask a question? So my understanding is EMPA-KIDNEY enrolls patients down to 20. Do we know, first of all, is that true? And secondly, presumably there's been no issue there. The trial, as far as I understand, is recruited very well.
Yeah, I would say, I mean, in fact, that's true, John. EMPA-KIDNEY is recruiting patients from 20 and above, and it's doing it for diabetics and non-diabetics, and even with type 1 diabetes. I don't have any information on how patients are doing, but I fully agree with Glenn that this is not a drug to lower glucose. And this is a drug with multiple mechanisms. By the way, before going back to David, I would ask you, John, and don't spend the rest of the year because it's a complex question, but which are the mechanisms that you as a cardiologist think are playing the biggest role in protecting patients in terms of heart failure and cardiovascular outcomes from your vision?
Well, so what we know, other than the fact that these drugs are very effective in reducing important clinical events, is that they also make the unhealthy, enlarged, dilated left ventricle get smaller and contract better. Now got 3 left ventricular cardiac remodeling studies showing that. So somehow or another, they're doing something good to the heart. So we know obviously they protect the kidneys, but we certainly know that they do good things to the heart. How that is, Ricardo, I don't know for sure. Obviously there is some hemodynamic effect. That's also been demonstrated recently. So when you give these drugs to patients with heart failure, you reduce their cardiac filling pressures, and with that, their left ventricular wall stress. Presumably that's got something to do with their diuretic action, but there must, I would think, have to be some additional effects. And then after that, it's purely speculative. I mean, as you know, Ricardo, probably better than I, there's been a lot of talk about whether or not these drugs favorably modify myocardial metabolism, which is abnormal in patients with heart failure, improve cardiac energetics. But there are also other things. I mean, these drugs reduce urate, increase magnesium, don't lower potassium. All of those things are actually quite important in heart failure. They increase hemoglobin and hematocrit. Many of our patients with heart failure are anemic. And, you know, heart failure fundamentally is a problem with reduced oxygen delivery to the metabolizing tissues. Cardiologists tend to think of that in terms of blood flow and cardiac output, but it's actually also to do with the oxygen content of the blood. And if you've got both reduced oxygen content and reduced flow, that's a sort of double whammy in terms of peripheral oxygen delivery. So it's likely, like all drugs, to be multiple different things.
So let me go to David. Thank you very much, John. Let me go to David with a question from Dr. Jose Luis Colina. And the question is exactly written like this. Dr. Wheeler, would you agree that Dapa is an anti-inflammatory drug for the renal glomerulus?
I'm not sure I do, because I don't feel we have a lot of evidence for anti-inflammatory properties. I think, as John and Glenn have suggested, I don't think we fully understand the mechanisms of benefit, particularly the breadth of benefits that we see in these patients, which certainly were unexpected from my perspective. But I don't think we have any evidence for direct anti-inflammatory properties, you know, reductions in CRP, reductions in kidney inflammation. I think that the favored mechanism of action in the kidney is around reductions in intraglomerular pressure, which is why we believe we see that acute drop in EGFR at the beginning of these trials when we put patients onto these therapies. But we don't fully understand how these drugs work. And so there are, of course, other mechanisms that could be operating that we don't fully understand.
So let me ask you, back to you, John, a question from Dr. Roberto Baca. What's your vision, and this could go for everybody, what's your vision on safety of the combination of Dapa and diuretics in patients with significant heart failure?
Well, I have more than a vision. I think we've now got very, very solid evidence. So I hate to say, Ricardo, we rather embarrassingly were very concerned about this when we planned Dapa-CKD, because nobody had ever really given an SGLT2 inhibitor on top of a conventional diuretic, usually a loop diuretic, in almost everybody, which of course is what the case is in patients with heart failure. And in addition, of course, all those patients were on a RAS blocker. Most of them were on a mineralocorticoid receptor antagonists. We were worried we were going to cause hypotension, hypovolemia, might even cause worsening kidney function, because we've been told about this at least initial diuretic action of SGLT2 inhibitors. So we watched this very carefully. We brought our patients back, believe it or not, just 14 days after randomization to check them over, to see whether we might need to reduce their dose of conventional diuretic therapy, make sure things hadn't got worse. What happened? There was no evidence of dehydration, no evidence of volume depletion, no evidence of hypotension. There was very little change in diuretic dose in the trial. We've published this, we've examined it in great detail. So in fact, you can give SGLT2 inhibitors safely on top of conventional diuretics and other drugs of the type that I mentioned. And of course, we now have 3 trials showing that, not just DAPA-HF, but also the Emperor Reduced trial and the Soloist Worsening Heart Failure trial.
Okay, so thank you very much, John. Let me just read what Dr. Leda Lotaif is posting. And she says, though MPKD is recruiting patients with eGFR of 20 or above, wouldn't the patient need minimal renal function for this drug to act? Will there be a sub-analysis of patients with lower GFR so we might see the beneficial effect of these drugs on kidney and cardiac events? I'll approach the first part and then ask Glenn and David to tell us what's going to happen with the data with Dapa-CKD. There's already some evidence with canagliflozin, with a study that Dr. Bakris published and presented at ASN, in which they followed a set of, I think it's 164 patients that had GFR below 30 and that continued using canagliflozin all the way till being on dialysis or getting transplanted. And even in that population, they found that the slope of decline on eGFR improved. David, could you tell us what do you think on Dapa and what to expect in terms of analysis?
Well, we have done an analysis of patients who went into this trial with stage 4 CKD. And Glenn led that analysis, so I probably should let him comment on that.
You're right. I should have said Glenn.
Well, just very quickly, similar to the analysis from Credence, but with a much larger subpopulation. If I'm not mistaken, it was 624 patients who were enrolled with stage 4 CKD, that is estimated GFR below 30. We found significant benefits. They were consistent with the benefits observed in persons with higher GFRs, including attenuation of loss of GFR. And again, no increase in serious adverse events, a decrease in serious adverse events. And I should also point out that our group, as the three of you know, has also prepared an analysis of acute kidney injury, which I know is a major concern for providers of care, because patients with underlying advanced chronic kidney disease are at a much heightened risk of developing acute kidney injury, essentially to any insult. And in Dapa-CKD, although there weren't formal evaluations each and every time patients were seen, we did see a reduction in the investigator-reported AKI events and in our best proxy for AKI over time. So yeah. I think we can use dapagliflozin safely in stage 4 CKD with efficacy parameters that are similar to the overall population.
Yeah, thanks.
Ricardo, can I'll just...
Yep, go ahead.
I don't know if you can see this slide, but this is heart failure. And so this is the blue line is the continuous, blue line is the continuous hazard ratio for the treatment effect. So if it's below 1, it indicates benefit of dapagliflozin compared to placebo. The interrupted red line was the overall treatment effect, so 26% relative risk reduction, hazard ratio of 0.74. But interestingly, look at what's happening down here at the lower end of the eGFR range. Now in Dapa-HF, we only went down to 30, but our colleagues in the Emperor-Reduced trial included patients with an eGFR as low as 20. And they have exactly the same findings. They have a figure that looks almost identical to this, except their line goes down to 20. So there's absolutely no indication of a diminishing treatment effect as the eGFR declines, which of course is very intriguing. Now, this is for a heart failure endpoint, but I think we believe the same is true for kidney endpoints as well.
So this is really interesting because it links very well to the next question, which is a bit wild. Dr. Osvaldo Sáenz Cortés has a sort of a wild question that could fit for a cardiologist or a nephrologist. And the question says as follows: what's your opinion about treatment with SGLT2 inhibitors in patients with HFrEF in dialysis when they still have residual kidney function? Do you see that as a possibility?
It's one for the nephrologist for sure.
For both.
So my logic is this, that these drugs work via the kidney, we believe. There are SGLT2 co-transporters in the proximal tubule, and I don't think SGLT2 co-transporters have been identified in any other tissue in the body. There's SGLT1 co-transporters in the gut. We know that. So to me, it's illogical to believe that these drugs would work with no kidney function, but they do seem to work in patients who have very low levels of kidney function. So it is feasible, it is possible that in dialysis patients with some residual kidney function, there may be benefits of these drugs that could be cardioprotective. We're obviously not worried about the renoprotective side at that point, although preserving residual renal function may be a good thing in a dialysis patient. But maybe there are cardiovascular benefits, and maybe we'll do a trial one day in patients on dialysis. I don't know. I hope so.
Yeah. Well, there's one very fast question from James Castle, which asks that I'll answer myself. Is the benefit of SGLT2 a class effect? I think that we all share that with all the data that has been shown, it's a class effect. And there's plenty of evidence of that. There's one question here from Dr. Lataif again, also concerned about urinary tract and yeast infections, and more on a practical ground. What she's asking is, what do you do if a patient has a severe infection or even a pyelonephritis on an SGLT2? Would you reintroduce the drug after resolution of the infection? I would say before anything that, in fact, severe urinary tract infections were almost absent. So we are talking mostly of yeast and limited urinary tract infections. So my opinion would be to go ahead. Of course, if the patient has a problem of voiding and has recurrent infections, I would think it over couple of times and probably not do it. But what would be your opinion, Glenn?
I take the exact same approach, Ricardo. I advise patients. For instance, I saw patients earlier this week and gave them advice to shower after exercise, to not wear excessively tight clothing, particularly in the summer with sweating, and that there is a risk of yeast and fungal infections in men and women. But good hygiene practices can eliminate the vast majority of them. And I have had the occasion to have a patient with a urinary tract infection and who was on SGLT2 inhibition, a couple. And I've held the drug during the infection, and I've held the drug for a week or two after the infection, and then I've reintroduced the drug with reminders about good bladder hygiene, and have seen no persistent infection.
Okay, and anything different that you would add, David, or you agree?
No, I agree. I just think we've got to distinguish mycotic fungal genital infection from bacterial urinary tract infection. The first occurs more frequently on these drugs. I don't think we've got good data to suggest the second occurs more frequently, certainly in the context of the studies that we've done. So I think we should distinguish those two. Having said that, of course, diabetics are more prone to urinary tract infection because of their glycosuria, and I think we have to bear that in mind, and I'd agree with Glenn on the approach. But I certainly tell patients they might develop mycotic fungal infection because that's fairly common, and just talk to them as to how to deal with that, because I think that is worth warning patients about with this class of agent.
Ricardo, I mean, I agree with everything that the others have said, but I have to say that we're told from the early studies that genital fungal infection can occur in 5 to 10% of patients, but we've simply, at least in cardiology, just not seen anything like that frequency. And I wonder if it goes back to what you and Glenn mentioned earlier, which is, of course, firstly, if you're not diabetic, there's probably not much increase in urinary glucose secretion. Certainly your hemoglobin A1C doesn't change in a meaningful way. And secondly, of course, if you've got kidney impairment, which all of your patients do, and about half of mine do, then again, you're not putting much more glucose into your urine. So if you're a non-diabetic patient with CKD or with heart failure, I suspect your likelihood of a genital fungal infection is actually very low indeed, simply because you're not actually increasing your urinary glucose excretion very much. And that's the risk factor.
Okay, guys, well, we're getting close to the end. Let me just read a question for you, John, from Dr. Jose Luis Colina. And he states what you think and asks me to ask you about it. Dr. Murray thinks that dapagliflozin results depended on regular doses of other medications in Dapa heart failure subjects, in part. And we might think that it also applies to Dapa CKD. Is this statement correct, or what's your vision, John?
So if I said that, it was a mistake, because I certainly didn't mean to say that, because in fact I know the opposite is true for most drugs. So why do I say the opposite is true? Because we've been able, obviously, in the Dapa-HF data set to look at the effect of dapagliflozin according to the background therapy. Now, I can't really look at people not taking a RAS blocker, because 95% of people were on a RAS blocker. Can't really look at people not taking a beta blocker, because 95% were on a beta blocker. We have looked at those taking an MRA, yes or no, and it didn't matter. The effect of dapagliflozin was identical, whether you were taking an MRA or not taking an MRA. We've looked at people taking ARNIs, we looked at people taking digoxin, you name it, ivabradine, people with devices. The effect of dapagliflozin was exactly the same. We've also looked at drug combinations and doses of drugs. So if you were on a high dose of a RAS blocker or a low dose, if you were on a high dose of both a beta blocker and a RAS blocker versus a low dose, no matter what we looked at, Ricardo, the simple message was the treatment effect of dapagliflozin was the same. So really what I was trying to say was that this is an additional benefit. It's not dependent on other drugs. The remarkable thing is that even in very well treated patients who sadly remain still at high risk, we get this additional incremental and we believe independent benefits of an SGLT2 inhibitor.
Thank you, John. I think it was very, 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 very clear. So guys, we only have 3 or 4 minutes. I want you to ask you if you have anything in particular you want to conclude. I'll start with the way my screen is from the bottom up. Glenn, any final comment you want to add?
Just to complement the responses with respect to infection, I think it's important to remind the audience that when we carefully looked at mortality, and there's a paper in the European Heart Journal describing causes of death and the mortality rates in multiple patient subgroups, that we saw lower non-cardiovascular mortality in addition to lower cardiovascular mortality, including fewer deaths related to infection. So I've heard a number of concerns, and this, echoes one of David's comments. Clearly, mycotic infections of the perineum are more common, but catastrophic infections like what we refer to in the US as Fournier's gangrene are less commonly seen, and deaths from infection and deaths from other non-cardiovascular causes are seen less commonly in the dapagliflozin treated patients.
Thank you very much, Glenn. David, any conclusion? Any final comment?
I'd like to just conclude by thanking the Latin American investigators for their tremendous effort in Dapa-CKD. There was one point where we thought this would become a Latin American trial. We wanted a global trial, but the investigators in your region were recruiting so fast that we were at risk of the whole trial being recruited in Latin America. So thank you to everybody for their efforts in helping us develop this fantastic database that we now want to translate into better outcomes for patients.
Thank you, David. And yes, let's keep on believing on Latin America, because we can deliver. John, any final comment?
No, just to thank everybody for the questions, for being so interactive. It's always good to hear interesting questions, makes us think about the data.
Well, guys, I have to thank you, the three. A final comment that I would say that needs to be addressed in the future is that we have challenges. One challenge is not only knowing what's good, but implementing. Implementation is really important. And a second challenge that we have to face very carefully is to understand that we, with other specialists, work together for the same goal. So here's cardiology, but we need the endo people, we need everybody, and we need to understand that the patient's one, and whatever is a benefit for the patient is what's important, and we should all work together. This has been a great symposia, fantastic presentations from you three, my friends, and the Latin American Society is very, very grateful, I know, for this symposium, and we're just on time, 2 minutes early, to say goodbye to everybody and to everybody to get ready for whatever next activity they have. Gracias, amigos. Muy buenas tardes a toda la comunidad. Me disculpo por haber hablado fundamentalmente en inglés, pero así fue la instrucción, en inglés para las preguntas. Espero que el simposio haya sido exitoso y que haya sido del gusto de todos los que han tenido la oportunidad de estar en él. Para nosotros ha sido un gusto y muy honrados de participar. Muchas gracias.
Buenas tardes.